Welcome to the Healthy Matters Podcast with Dr. David Hilden, primary care physician and acute care hospitalist at Hennepin Healthcare in downtown Minneapolis, where we cover the latest in health, healthcare, and what matters to you. And now, here's our host, Dr. David Hilden.
Hey, everybody, and welcome back to the podcast. I am your host, David Hilden, and this is episode 22. And we're not going to talk about an illness today, but about something that will still impact millions of Americans, especially the most vulnerable among us. And that is the deep, sweeping cuts to Medicaid that were included in the recently passed Big Beautiful Bill, H.R. 1, out of the United States Congress. These changes might be buried in the legislation, but their effects will be felt in exam rooms, emergency departments, and communities across the country. We're going to dig deep into what these cuts are going to mean for your hospital, your community, and maybe even your own care. To help us unpack what all of this means, I'm joined by someone who knows the healthcare policy landscape inside and out, Susie Emmert. She is the Senior Director of Advocacy and Public Policy at Hennepin Healthcare. If anyone can help us make sense of what's to come, it's Susie. So welcome to the podcast, Susie.
Thank you, Dr. Hilden. It's great to be here.
So before we get to the bill and what all that means for Medicaid and healthcare, can you first share with our listeners what you do?
Sure. So I've been with Hennepin Healthcare for just over 6 years now, and the role of my office is to represent Hennepin Healthcare primarily at the state and federal levels. So we spend a lot of our time at the Minnesota State Capitol in St. Paul, talking to elected officials, talking to our Department of Human Services, our Department of Health, et cetera, about the work that we do at Hennepin Healthcare and the importance of it, and trying to make changes there so that things can be most effective for our patients and for our teams in the organization. And we also go to Washington, D.C. and do the same thing.
You know a thing or two about Medicaid. I'm well aware. Listeners, she knows more than a thing or two about Medicaid. You've been advocating for Medicaid for a long time.
Oh, yes.
Tell us about that if you could.
Absolutely. So I've been working on Medicaid for probably 20 years now, maybe close to I'll say 20 years right now, but really since the beginning of my career. So I've worked initially when I started, I worked in the community with people with disabilities and other folks who access Medicaid, and have just kind of worked my way into policy and advocacy as well. So really started in the direct practice world and have been in policy and advocacy for about the last 15 years.
What is This Is Medicaid? Can you talk about that?
I would love to. This Is Medicaid is close to my heart. There was a coalition of folks that formed back in 2016 following the election, when we saw really clearly that Medicaid was going to be under significant scrutiny, attention, folks looking at it kind of in a similar way they did this last year, that because of the size of the program, this was an opportunity to take funding from that program and use it elsewhere. And so back in 2017, when this focus was originally on Medicaid, we were able to stop that bill from passing, and that would have done significant damage way back in 2017. Unfortunately, it did come back again this year, as we all know, but there are just so many advocates for Medicaid out there working on this. And here in Minnesota, This Is Medicaid continues and has been a really strong and scrappy coalition of folks who have come together and really put a lot of their time and attention into protecting this program, both for patients, clients, providers, everybody in Minnesota.
So 9 years later, we're going to talk about more bills, and we're going to talk about Medicaid. I got wind of This Is Medicaid. That's the name of the coalition that Susie was instrumental in working on way back when, before you even were really working here at our hospital. So now let's talk about 2025. Congress has passed a bill. There's all kinds of nuances about budgetary reasons and all that, but we're going to focus on the effects on Medicaid to our patients, communities, and our hospitals. So for listeners, it's been dubbed the Big Beautiful Bill. Now, that is a political term. There's some things that aren't so beautiful for our Medicaid patients or communities. So if we could delve into that, could you talk about what some of the biggest provisions in the new U.S. law are as they relate to Medicaid?
Yeah, I'd be glad to. And you're right. It is called, the Big Beautiful Bill. And we are going to call it that because we want to make sure that the community understands that's what is included in this bill is actually a lot of really significant changes to Medicaid, to SNAP, to student loans, to things that we really care a lot about and that impact so many people in our community. So I'll spend the majority of my time, of course, on Medicaid. That's really where I spend my time. time, but we just have to remember it really came for programs that give a hand up to people to help ensure that folks are able to do what they need to do, that they can get the health care they need, they can have food support, they can have access to student loans. Not everybody can pay for their education straight up. So it really came for programs like that in order to, frankly, give some tax cuts to other folks. And so
rich folks, Susie.
Well, to other people who maybe don't qualify for those programs.
Okay, that's a nice way to put it.
Yes. So I'm going to talk first a little bit about what Medicaid is. I think there's a lot of misunderstanding about the program. Medicaid looks different in every state. So in this country, we have Medicare. That's for the folks who are over 65. That's really the same in all states. It's a federal program. The federal government has significant control over Medicare. And then Medicaid looks different in every single state. And it's even got a different name in every state. So a lot of people don't even know that they're on Medicaid, that their health care is being provided through Medicaid. In Minnesota, for example, we call it medical assistance. And so you'll often hear people here talk about MA, et cetera.
Yeah, we talk about MA all the time.
Absolutely. And sometimes it's provided through just a health insurer, like any of the number of health insurers that we have here. And so people think, oh, that's my health care, not Medicaid.
Yeah, that doesn't affect me. Yeah.
Right. A lot of people don't realize how kind of prevalent Medicaid is. It's over 1 million Minnesotans are covered by Medicaid. And it is a state and federal partnership where Medicare is paid for by the federal government. Medicaid is paid for by the state and federal government. It's like an agreement, frankly, between the state and federal government about how we're going to care for people and we're going to provide the service. And states put in certain amounts of money and the federal government might match that money or a certain percentage of it. So that's how it's a partnership. And this is the coverage for people with disabilities. Some seniors qualify in addition to Medicare, children, pregnant people, and most recently through the Affordable Care Act, low-income adults. And that's when you hear people talk about the expansion population, it's low-income adults. And that's where a lot of this bill really kind of came after those lower-income adults in order to pull funding from that.
So you mentioned Medicaid expansion. I've talked to loads of people in the state of Minnesota, even those of us who practice medicine and said, well, we're not in a Medicaid expansion state. Oh, heck yes, we are.
Heck yes, we are.
Yeah, but it's that Medicaid benefits vary by state.
Absolutely.
Is that true? And in Minnesota, they were relatively decent for a while. It covered more people, but that is not the case in the 50 states in the District of Columbia.
Absolutely. That's a great point, Dr. Hilden. So the Medicaid expansion is a great example of how Medicaid looks different state to state. So Minnesota expanded Medicaid way back when the Affordable Care Act passed and gave us the option to do that. And that meant that we said we are going to cover folks up to 138% of poverty. And these are still people, many of whom are still working. This does not mean that they're not working. There are many people who are experiencing homelessness and housing insecurity, challenges with food insecurity, transportation, et cetera. Tends to be lots of challenges. And you often hear the term 138% of poverty. And what the heck does that mean? It means somebody who makes about $1,800 a month or less. So that's about $21,000 a year. So that means in order to qualify for Medicaid expansion, you need to have an income that's less than $21,000 a year. And I think most folks would agree that is a significantly low income. These could be people who are working in the gig economy, caregivers, restaurant workers, sometimes folks in industries where sometimes it's hard to get more hours because your employer may not want to provide your health care coverage or other reasons. You can't get those hours. You may be caring for kids, et cetera, or other things. But these are very significantly, I think the number is around 91%. The Urban Institute said that folks are actually working in part of the Medicaid expansion population.
That's just a staggering number to me. It's staggering, and it's not very large.
No.
$21,000 a year.
Absolutely.
And in other states of the country, and maybe you're listening to this podcast from one of those, it's probably a lesser amount.
Absolutely.
Even than that.
Yep.
Because your state did not expand Medicaid.
Absolutely.
Okay, so that's a good baseline of what the Medicaid program does, who it covers. What is changing now in the big, beautiful bill that came out of the federal government in Congress?
Yeah, well, I could be here all day talking about this, but I don't think your listeners would like that. So I'm going to narrow it down to some of the big provisions that folks are really concerned about, and particularly us as a safety net hospital. So I'll focus on two categories. The first one I think about is people and paperwork. And the second one I think about is like financing, the more kind of wonky, how you pay for a hospital or another provider. So thinking about people and paperwork, really what this bill is going to do is make it harder to get and keep care. Whereas right now, the Medicaid expansion has pulled in a lot of folks to have health care so they can get their primary care. They can get to the dentist if they can get they can get the care that we might take for granted. And what that does, it makes sure that these folks are not waiting until the emergency department, waiting until an infection, waiting until something is far more severe, more dangerous for them, more problematic, things that pull them out of work, for example. And it also helps to reduce the uncompensated care, because we're not just talking about taking away coverage and what it means to be an individual person who has healthcare coverage. What we're talking about as well, we have to think of the other side of that is I'm still going to need care whether I have that health insurance or not. And hospitals like Hennepin Healthcare and all hospitals are going to end up still providing that care. The members of Congress have made a decision that they're not going to always pay those hospitals and other providers for care. So it's really a double-sided kind of impact. But when you look at patient enrollee specific and kind of how it creates that uncompensated care, the way it saves money is to take away coverage.
It takes away coverage. That's how it saves money.
That's how it saves money.
Everything else is a smokescreen.
Exactly.
It just takes away coverage.
It takes away coverage. And so just some of the examples of what's changed in the bill. So increasing eligibility requirements. That means that they're going to make you complete paperwork more often. And it's not easy paperwork. We're talking about submitting bank statements, verifying income, all of these things that are not easy to verify, especially if you are a person who might be, like I said, in the gig economy. Maybe your hours fluctuate. Maybe you worked less over the last 2 weeks because you were taking care of a parent or a child. These are very complicated things. We're going to be asking individuals to keep showing up to do this
over and over.
Over and over.
Show us what you've done. Show us the paperwork.
Exactly.
It's an efficiency nightmare.
Exactly. It's just more paperwork, more burden. And you may think, oh, what's the big deal? It's just some paperwork. No, this is not just some paperwork. These are things that end up being significant barriers, often to folks who already have significant barriers. And that forces the state and the counties to spend money on pushing paper. That's money that we could be spending on providing health care. So there's that shift as well that's going to be really problematic. So those eligibility requirements are going to be very difficult to be able to keep people on Medicaid.
Before you move on from that, but Susie, people are watching video games and they're eating pizza at home and they're not getting out to work. We need to ensure all this fraud. What do you say to that?
Well, what do I say to fraud? The majority of folks, like I already mentioned already, are working. They're working in maybe ways that aren't able to keep them on the Medicaid program. Medicaid is a healthcare program. It is not a work program. It is here to provide healthcare coverage. If we want to do a work program, let's provide work programs to help people get to work. This does not help people get to work. This just piles more and more barriers and burden on top of not just them, but on top of the folks trying to keep them covered as well. What it's going to actually end up doing is forcing people to rely on that emergency care. It's going to force people to skip that primary care appointment. It's going to force people to just go to the emergency department. And I don't know about you, Dr. Hilden. We hear a lot about how our emergency departments are already backed up. They're already struggling to be able to move people into beds where needed. And this is just going to cause more additional challenges to that.
Yeah, and listeners, if you didn't sense the sarcasm in my question, I was really pushing that issue because that is not the problem. I'm not saying that there's not one person out there who's maybe milking the system. That is not what is happening.
That is not what is happening
not what's
here.
happening. They are indeed going to still need care. We're going to talk later in the show about why should you, if you're not on Medicaid, care about that. We're going to talk about that because of what it does to our healthcare system. I liked what you said. It's not Medicaid is a health insurance plan. It's not a jobs plan. And it's just, I think it does have just about the opposite effect. Most of my patients do indeed have Medicaid as their coverage. And these are hardworking folks. or the reasons why it's hard to work. And many of them, anyway, are working. This doesn't do anything. It's important that we say that work requirements are simply a way to get people to lose their coverage.
Yeah.
And then they come to our emergency department.
Absolutely.
So you've talked about eligibility. You've talked about work requirements. What else is there?
A couple other ones I'll just touch on as far as that paper and people category. Retroactive coverage is one. So if somebody lapses in their healthcare coverage, which is going to happen when we increase these other burdensome reporting eligibility requirements, the retroactive coverage is changing. And so right now it's 90 days. And so if I come into the emergency department and I don't have coverage, a financial worker at the hospital can help me get coverage, and it goes back 90 days to what would be covered under Medicaid. This shortens that to 30 days. And I don't know if other people have noticed, but sometimes it takes a really long time to get through health insurance, to get through all the different things you have to do in order to get coverage, et cetera. That's going to be really problematic. And again, not just for people, that's going to mean that our health system is not going to get reimbursed for providing that care for folks. The other piece is cost sharing. So there is an element in the bill that would require cost sharing. And remember, I said these are folks who make under $1,800 a month. So a $5 copay or even a $2 copay may not sound like a lot to you, but that might mean that person is not going to eat that day. And they are going to have to make choices. Are they going to pay for that prescription? Are they going to pay for their transportation to get to their job or whatever it is? So those cost sharing elements sound really minor, but they're actually significant barriers that would keep people from getting the care that they need. And then I want to touch on one other thing that's part of that people impact. There's an immigration impact here too. And they're changing kind of who is eligible, including removing eligibility for people who are here legally. Lots of different folks who are here legally are no longer going to have access to Medicaid or other programs as well. So there's some changes around what's considered a qualifying individual. And I think that's going to be really significant for many communities. That's going to just result, again, in more people losing coverage, greater uncompensated care, delaying emergency care, all of these things. These changes don't help anyone. All they do is take away coverage to save money.
We're going to talk about the financial healthcare delivery aspects of it as well. We're going to talk about the effects on your hospital, whether you come to Hennepin Healthcare in downtown Minneapolis or maybe whether you go to a critical access hospital in a rural portion of Minnesota or another state. So we're going to talk about some systemic things and financial things as well. But everything you've just mentioned, those are my patients. Those are the people I see and my colleagues see, and those are patients that are scattered around our country in every single county. And it's just to save money for other reasons.
Right. You know, Medicaid is not a perfect program.
Right.
Our health insurance, in this country is very imperfect. There are so many things that we could change that would make it better. This is not how you make a program better. This is how you make a program more difficult to access. That's it.
So, Susie, there's clearly a lot to talk about here, but we're going to take a quick break. We are talking with Susie Emmert. She is the Senior Director of Advocacy and Public Policy at Hennepin Healthcare here in downtown Minneapolis, and we're talking about the challenges facing the healthcare system in this country due to recent legislative changes about Medicaid. Stay with us. We'll be right back.
When Hennepin Healthcare says, "We're here for life," they mean here for you, your life, and all that it brings. Hennepin Healthcare has a hospital, HCMC, a network of clinics in the metro area, and an integrative health clinic in downtown Minneapolis. They provide all of the primary and specialty care you'd expect to find, as well as services like acupuncture and chiropractic care. Learn more at hennepinhealthcare.org. Hennepin Healthcare is here for you and here for life.
And we're back talking with Susie Emmert about the big, beautiful bill, but specifically about the effects of federal legislation on Medicaid. You talked, Susie, about people and processes before the break. How does this affect individuals? Now, let's talk about the second thing you were talking about, and it's healthcare finance.
Yeah, thank you, Dr. Hilden. So this is kind of the wonkier side of things that the general public is lucky to not have to dig into those details. But those of us in policy and advocacy think about all the time is the financing side of it. So two things I'll talk about. There was a lot of this emphasis on waste, fraud, and abuse. And this bill does not address waste, fraud, and abuse, just to be perfectly frank. A couple areas where there were changes made are in things called provider taxes and state-directed payments. And you may have heard about those a little bit in the news. I think Dr. Oz talked about them a number of times. And these are ways that we finance the state share of Medicaid and that we invest in our Medicaid programs. These are things that the federal government provided for us to participate, these mechanisms.
Legal ways to cover the
Absolutely.
state's share. Yes.
Absolutely. And so there's significant changes being proposed there. As a safety net health system, we have been able to access for a number of years a mechanism called state-directed payments. And this is a way that we actually pay the state share as a hospital, and then we're able to draw down federal Medicaid dollars. So that will make changes where in 2028, what members of Congress have directed is that those payments will decrease by 10% each year until they reach a threshold that has to do with Medicare payments. So it's a significant reduction over time that we're going to see. Other hospitals are more and more accessing these types of programs, and they're going to see the same thing. New programs are actually going to start at that lower level. So that's a significant change in how we finance healthcare, especially hospital financing. The other is what's called a provider tax. And this is another way that states are able to have providers help to pay for that state share and draw down those federal dollars. That's going to be limited in similar ways where, starting in 2028, they're going to start reducing what the limitations are around those taxes by 0.5% every single year until they get to a certain threshold. And so those sound really wonky, but they will have significant impacts and they will pull significant funding out of our healthcare system.
So if I'm a listener who's not real clear on all of that stuff, how are those two things not just giveaways to hospitals and doctors and clinic systems?
They're all really a recognition of the fact that Medicaid reimbursement has not been at a place to cover our costs ever.
But I want to reiterate that, though. The amount that hospitals and clinics are paid to care for Medicaid patients does not cover the cost of doing that. And you can't run businesses effectively when you're being paid less than it costs to provide the service. So I know that's a little bit wonky, but it's important to just kind of put that out there, I think. Mm-hmm. Okay, so let's talk locally. You work in Hennepin Healthcare in downtown Minneapolis. We are a large urban safety net hospital. These cuts affect us enormously. They also affect hospitals across this country, in rural communities and in larger communities that care for a large number of Medicaid patients. What are the effects going to be? And then somehow I'd like us to delve into why should people care if you're not a Medicaid recipient?
Well, first, I just want to touch briefly on what is a safety net hospital, because I think that's a term that we all kind of think we know what it means, but you will be surprised to know there's actually not a specific definition of a safety net hospital. We work really closely with America's Essential Hospitals. That's the National Association for Safety Net Hospitals. And the way they talk about hospitals is these specific hospitals serve low-income, uninsured, and underinsured populations, and they really share a mission to care for everyone. And that includes those with limited access to health care coverage due to financial circumstances or health conditions. Hospitals like ours really rely heavily on programs like Medicaid and Medicare. And when Medicaid doesn't reimburse to cover the actually cost of care, when you're an organization like ours, and those are your primary reimbursement mechanisms, it's not kind of hard to see on the pie graph there about how the costs are just far bigger than the reimbursement. And so safety net hospitals, we continue to make it work, even in those circumstances, because it is such a critical asset to all communities to provide these very essential services. Many of us provide trauma care and other public health initiatives that aren't necessarily always going to be provided in other places. And so with that, we have to think about Medicaid as really the thread that goes through all of these services that everyone relies on regardless of your coverage. So if you have commercial coverage, you are still very likely relying on a level 1 trauma hospital, possibly on the worst day of your life. You are relying on a trauma level 1 hospital that very likely is heavily funded through Medicaid. And so we have to think about Medicaid, like I said, as that thread through that safety net that keeps all of these services functioning. So for us specifically, 62% of our patients that receive our trauma care are covered by Medicaid. That means that that service, our level 1 trauma care, is available regardless of your insurance. And you better believe you want to have access to a level 1 trauma center on that terrible, terrible day in your life or someone you love's life. The other area, if you think about mental health care as well, for us, more than half of our patients receive inpatient mental health care are on Medicaid. Again, mental health care doesn't matter if you're on Medicaid, if you're on commercial insurance, et cetera. But without Medicaid funding a significant amount of that program, that's what helps keep it open. Additionally, if you think about training and access, we are one of the biggest provider of medical education. 60% of the doctors in Minnesota are trained at Hennepin Healthcare. And you think about it again, if Medicaid is a significant funder in our hospital, that is what is shaping some of the research and delivery of healthcare and ensuring that those medical providers, especially physicians, have a place to practice and learn. And I'll just wrap up with addiction medicine is another one. 73% of our care for patients accessing addiction medicine is paid for through Medicaid, and we know addiction absolutely affects every single person. And so we want to make sure that addiction medicine is able to be covered. Burn and emergency hyperbaric care is another one. Our regional burn center and 24/7 hyperbaric oxygen services, if those aren't available to you, you are potentially traveling out of state. Those are available 24/7, and these are what we rely on during mass casualty events, carbon monoxide poisonings, all kinds of emergency situations. And so folks would need to travel sometimes hours for that type of care. And so we just really have to think about Medicaid as really part of the infrastructure of all of our hospitals, not just those safety net hospitals that are very specific in that case. We all rely on each other. We work with other health systems constantly. Some of our colleagues in greater Minnesota, hospitals really rely on our level 1 trauma care, and we need to be here. It's not possible to have a level 1 trauma care center in every community in the state. And so you really have to rely on those trauma care centers around the state. If they're heavily funded by Medicaid, they could be more at risk.
Yeah, we have a helipad and a backup helipad. That's for people coming from all over the upper Midwest.
Absolutely.
So I don't think I could have come up with a better summary of the effects on our large safety net hospital and why the general population should care about. That was absolutely brilliant, Susie. That was just brilliant. So I'm listening, and I'm in greater Minnesota, which is what we say in Minnesota for rural Minnesota. Somebody asked me that
once. I forget that the people don't say that.
Yeah, so if you're in a rural county, and Minnesota is generally a rural state, we want one giant metropolitan medical center and a few other really wonderful medium-sized cities, but largely we are an agricultural, rural, northern wood state. So I'm living in one of the smaller communities, and that's true. I get all of that. That's that big hospital in downtown Minneapolis, but frankly, that ain't going to happen to me. It's not really my problem. Why should I care? I live in rural Minnesota. Why should I care about cuts to Medicaid or what happens to your big hospital downtown Minneapolis?
Well, you should absolutely care about your local hospitals, because once those local hospitals that are very dependent on Medicaid themselves, because a lot of people in greater Minnesota actually rely on Medicaid. If you look at farmers, if you look at caregivers, Medicaid is really important to some of those folks who are employed in greater Minnesota. And many people in greater Minnesota have a story about when they or someone they love needed that type of emergency care that you can't get in greater Minnesota. I have heard so many stories about a parent getting injured in a farm accident. In Minnesota, we love our fishing. A child being a near drowning in a Minnesota lake in greater Minnesota, or another injury in a snowmobile accident. We love our outdoor winter sports here. These are some folks' worst day of their lives, and they may not have, a local hospital, because Medicaid is so integral to greater Minnesota. It's going to very much challenge those greater Minnesota hospitals. And two, they may not have that trauma center that is accessible to them. We take a significant amount of folks who maybe start out at that local hospital in greater Minnesota, and they may not be able to care for the level of complexity of that patient due to their injuries or other challenges. and they need a hospital like Hennepin Healthcare.
So in 2025, our big safety net hospital is facing financial challenges. And this is before the effects of the new federal legislation take effect, which largely, many of them are in 2027. And yet already here today, we're facing financial challenges. So given all that, does our hospital and similar ones across this country, do we survive these Medicaid changes? And is there ever going back?
I think that's a great question, Dr. Hilden. And changes like this are kind of like, remember those puzzles where you slide over a square and it moves another square and then you get out of order?
Those.
I know they're very difficult, but that is a lot of what this bill is. And so I'm hesitant to sit here and say, oh, everything is going to be X, Y, Z, because things do change. And you better believe that advocates like us are going to be helping to shape what this looks like going forward. And so when I think about, are we going to survive? I look at the Affordable Care Act. There are things we have not implemented in the Affordable Care Act because they would cut significant amounts of funding out of our healthcare system, and we have delayed. Delay is going to be our motto, I think, in the next, coming years as advocates, because what we're going to do is try to slow down. I don't think I'm giving anybody a playbook here, but we need to look at what are these things that are coming and pull every possible lever to slow down or stop changes from happening. And there are still ways that we can do that. So Congress passes a bill like they did, and it was signed into law by the president. That doesn't end there. Really, the hard work kind of goes from there, where then you have departments like the Center for Medicaid and Medicare Services making the rules about what that legislation does. And that's where we have opportunities as the public to weigh in on those situations and to use the expertise of our health systems to say, that doesn't work that way, or that should work this way, or here's why we can't do that. And we will weigh in at every single opportunity that we can in order to shape the direction for that. They've already built in some opportunities to delay some of these because they recognize that these are very difficult things to implement. The level of administrative burden, for example, for work reporting requirements, there's already an opportunity to delay that by even another 2 years because they know that this is not flipping a switch, that these are major, major changes that they're making. And so I think that all of us as health systems, we need to look at what is coming this way, what can we change, what can we move, and we're going to keep advocating from here on out to be here for our communities.
That's reassuring. So, Susie, you did say it's not like flipping a switch and that this will get rolled out over the years. But some of these changes to Medicaid likely will come into effect, and some of them more quickly, some of them might get delayed. But what is the ripple effect of some of these changes? It affects our hospital, and then what?
Oh, that's a great question, Dr. Hilden. So the Medicaid, I'm here to talk about safety net health systems, but we are in a huge, healthcare ecosystem. So people in our institution and others, they may not be able, for example, to go home. Folks that actually do go home from here, they need care sometimes in their home. Sometimes they might need to go to a different facility that's not a hospital level of care. Those folks are impacted by this too. And so we're going to see more and more of those types of partners in the community that we work with so much. If they're not able to provide care because they're not getting paid for it, where do people go? We're going to see our health systems backed up even more. And for you, as a person on the street, that means that you're going to be waiting far longer in the emergency department in order to get your care. If you have to be inpatient in our hospital or any other hospital, you might be staying in that hospital a lot longer than you ever anticipated because there's nowhere for you to go. So I think those are just some of the ripple effects that we're going to see. It's not just about being in the hospital. It's about what you need when you're at home and what you need in order to get healthy again. We're going to see a lot more of those things. It's not just about, whether you show up at the emergency room.
Yeah, and let's be honest, the emergency department isn't the best place to get care. It is the best place to get care when you have an emergency.
Yeah. Emergency departments are not the place that we should be getting our basic care. If you have an ache or a pain that just doesn't seem right, you want to make sure you're able to go to your primary care doctor and get it checked out instead of waiting to go to the emergency room when it's far, far worse. And sometimes we have seen folks who it's too late to help them once you get to that point. And we want to make sure that we're helping patients as soon as possible.
So, Susie, if these changes happen, is there a way to go back?
Well, I am a huge advocate for Medicaid. I have been my entire career, but like I have said, it is not a perfect program. We could make many changes to healthcare in general in this nation, and we should. We need better than what we have right now.
Completely
Absolutely.
agree with that.
And that is something I think, frankly, everyone would agree with, regardless of political party. What we have now doesn't really work. And so I don't know that we can go back to what's happened. You know, the bill that passed is generation-changing policy. And so I don't think we can go back, but we sure better make sure when we go forward, we do it better as much as we can. It's going to be tough to do that with this level of reductions that are included here, like I talked about the financing, et cetera. But we need to get our best minds together to think about what should this look like.
Yeah, that makes perfect sense to me. I couldn't agree more. So before I let you go, if you could leave our listeners with a thought, what would it be?
Oh, a couple things. I don't mean to bring a dark cloud, but lately it seems like that's kind of what I do. We're not done yet. There's more proposals coming our way towards healthcare. Even as soon as this fall, we're hearing that there could be another bill that could impact Medicare, that could have, some additional Medicaid changes that they weren't able to get included this last time. We're not just hearing things in bills, we're hearing, executive orders and other things that are changing healthcare as we know it. So what I will say to folks is don't let up. We need to stay on top of these things. We need to track what's happening, and we need to make sure the people who are elected to represent us understand that many of these changes are not okay and they're not helping anybody. And their job is to help people. When you're an elected official, your job is to help your constituents. And so that would be one thing I would say is don't give up, don't lose hope. There are folks like me and you, Dr. Hilden, and others who are working really hard to use the mechanisms that we have to make changes to these so that we can do what we're supposed to be doing, which is to help people.
We've been talking with Susie Emmert. She is the Senior Director of Advocacy and Public Policy at Hennepin. And Susie, this was a gold mine of a conversation to delve into complex topics, but topics that literally affect every single one of our listeners. Thank you for being here.
Thank you so much for having me.
Listeners, thank you for tuning into this episode, and I hope you'll join us in 2 weeks' time for our next episode. And in the meantime, be healthy and be well.
Thanks for listening to the Healthy Matters Podcast with Dr. David Hilden. To find out more about the Healthy Matters Podcast or browse the archive, visit healthymatters.org. Got a question or a comment for the show? Email us at healthymatters@hcmed.org or call 612-873-TALK. There's also a link in the show notes. The Healthy Matters Podcast is made possible by Hennepin Healthcare in Minneapolis, Minnesota, and engineered and produced by John Lucas at Highball. Executive producers are Jonathan Comito and Christine Hill. Please remember, we can only give general medical advice during this program, and every case is unique. We urge you to consult with your physician if you have a more serious or pressing health concern. Until next time, be healthy and be well.